Good afternoon, and thank you for joining us today for the Defense Suicide Prevention Office and Department of Veterans Affairs webinar series on suicide prevention. My name is Mark Bates, and I'm the Associate Director for the Psychological Health Promotion Directorate, Deployment Health Clinical Center, Defense Centers of Excellence for Psychological Health and Traumatic Brain Injury. I will be your moderator for today's webinar. I would now like to introduce Dr. Richard Stoltz, the Deputy Director for the Defense Centers of Excellence for Psychological Health and Traumatic Brain Injury, otherwise known as DCOE or DECO. Sir, welcome.
Thank you very much, Dr. Bates. And listen, greetings to everyone who's joining us today. We're so happy that you're participating in this important presentation. Today I have the honor of introducing Dr. Keita Franklin, who is the Director for the Defense Suicide Prevention Office. Just a little bit about her background. Prior to her current role as the Director of DISPO, she served as the Behavioral Health Branch Head, where she was charged with leading the integration of the U.S. Marine Corps behavioral health programs. And before she was with the Marine Corps, she served as the installation and regional levels for both the U.S. Air Force and Army. She has worked in the areas of prevention, clinical treatment, child welfare, and program administration over a variety of different programs. Her specialty areas focus on the impact of deployment and trauma on military and family relationships, particularly spouses and children. She has published on deployment and psychological well-being on family relationships and alcohol-related issues. She has also served as an adjunct faculty member at George Mason University and Virginia Commonwealth University and has lectured on numerous topics impacting military service members, including deployment stress, secondary trauma, women's mental health issues in the military, parenting in the military, and behavioral health needs of today's service members. Dr. Franklin is a licensed social worker with a specialization in children and families and has a Ph.D. in social work. Please welcome Dr. Keita Franklin.
Thank you, Dr. Stoltz. I'm happy to be here this afternoon. This is our first DISPO Veteran Affairs combo webinar. It's the first of its kind, and it's actually one of 4 that will occur throughout this year, hosted by DISPO and the VA, and led actually by Wendy Lasco, the director of our DISPO Outreach and Education Program. So thank you so much, Dr. Stoltz. I am Keita Franklin, as he said, the director of the Defense Suicide Prevention Office, and for those of you that don't know, the DISPO office is the department's main effort for policy oversight, research, program evaluation, outreach, data and surveillance, and a host of other activities that occur across the department in the area of suicide prevention. And the Department of Veteran Affairs is our most important partner in that effort. So I'm really happy to be here today. I'm pleased that the Defense Center of Excellence was willing to host and moderate this event. And thank you so much to my dear friend and colleague, Dr. Mark Bates, who will be doing the moderation. You're in for a treat here today. I think all of you probably know that despite our best efforts, suicide continues to remain a tragic and urgent concern for all of us. This is probably why all of you have paused with us today to take a short break from your busy schedules and focus on this learning opportunity. I believe all of you are probably keenly interested in refreshing your knowledge on what it takes or what it means to take a public health approach to prevent suicide. This is certainly a necessary and holistic approach grounded in the evidence. I think that all of you will probably take away some application for your own service delivery areas. I'm confident that you'll be able to think through what's presented today and how that applies for your own area. So with that being said, it's just with great excitement that I turn this webinar over to 2 of our most experienced advocates and pioneers in the area of suicide prevention. You'll hear today from Dr. Adam Walsh, who is currently on our DISPO staff. He's our subject matter expert in the area of suicide prevention. He actually worked in the Marine Corps as a section head where he covered down suicide prevention and the community counseling capability there. Dr. Walsh has over 15 years of experience in studying and applying and developing suicide prevention initiatives, so I have no doubt that I leave you in good hands with him. And then also my dear friend and colleague, Dr. Thompson, his co-presenter from the Department of Veterans Affairs. Her title is Director of the National Mental Health and Community Engagement Program. She is responsible for both policy development, provider, patient education in the areas of suicide awareness and prevention, where she implements assessment and treatment strategies and disseminates new findings in the area of suicide throughout the entire VA system as well as the broader community. So without another second, I turn it over to these two experts. Thank you so much.
Okay, thank you, Dr. Franklin. We will now move on to today's webinar titled The Power of One, Maximizing a Public Health, Community-Based, and Holistic Approach to Suicide Prevention. At the conclusion of this webinar, participants will be able to, 1, understand the rationale and evidence to support a public health, community-focused approach to suicide prevention. 2, understand the importance of using a prevention science framework to guide and implement suicide prevention efforts. And 3, understand how population-wide suicide prevention strategy can leverage an entire community to prevent suicide. And now we'll turn it over to Dr. Walsh.
Thank you, Dr. Bates. Thank you, Dr. Franklin. I'm very honored, very privileged to have this opportunity to work with all of you, our great partners with the VA, the Defense Center of Excellence, and many other partners that are with us online. And what a great opportunity to speak with everyone from such a diverse background. We have individuals who are in the field representing the VA, working with our active duty service members as well in administrative roles and also in the field. And it's very befitting that we are talking about a holistic public health community-based approach because all of you are very much instrumental in understanding this framework and implementing a framework where all of us are responsible and all of us play a key role in preventing suicide. There's been a lot of research and a lot of momentum to move suicide prevention to a holistic public health approach. The Institute of Medicine has released several reports talking about the importance of a public health approach, which means we understand our population, we understand the risk and protective factors for suicide. Many of the risk and protective factors for suicide transcend different populations. However, depending on your specific population, there may be more of an issue or problem with certain risk factors, and there also may be more protective factors in particular areas. Maybe you're in a population where alcohol or trauma might be more of a risk factor for suicide, so you want to maybe focus more on that. Or protective factors, maybe you have a close-knit community and a lot of available community services, so you need to be flexible and tailor your approach based on your population. So understanding your population, understanding your data, and then leveraging evidence-informed, evidence-based interventions that are appropriate for your culture, appropriate for your setting and context, and then always evaluating. It's a feedback loop, always evaluating and assessing how effective these strategies are. And these can be interventions at many different levels. We'll be talking about that later, and a lot of different policies as well. So you evaluate, collect more information, and then you implement evidence-based practices, and you see how that works, and then you keep going. So this is not a static process. This is very fluid. Along with the Institute of Medicine, the World Health Organization released a report in 2014 really impressing upon people that we must take a public health holistic approach to suicide prevention. We can't just take one single approach because, as we know, suicide, its manifestations, its factors in understanding it are very diverse and very complex. Just about every article that I read these days opens up with suicide is a public health problem. The second sentence usually is suicide is very complex. And so we need to match that complexity with an approach that is very holistic. So today we're going to be talking about what public health suicide prevention models look like, the differences between public health approaches, maybe some different models such as a medical model, and understanding the Institute of Medicine model, the ecosystems model, and how you can implement it, and also share with you some examples of how you would do that in your community and based on your population. Okay, so this, the next slide discusses, how complex suicide is. We know that suicide is a culmination of complex interactions between biological, social, economic, cultural, and psychological factors operating at many different levels: individual, community, societal, and so therefore it really needs a comprehensive approach. And then understanding the community and what a tremendous resource your community is, and leveraging all the resources and all the opportunities for interventions within your community. So no single intervention can prevent suicide. Successful suicide prevention must incorporate the medical, also awareness and education, behavioral health systems, policies, especially with suicide prevention, policies around alcohol, policies around mean safety, working with your community organizations. All of these things must come together for us to prevent suicide. The importance of every intervention. So we know how complex suicide is, so we need a variety of different interventions. We need interventions that focus on heightened risk individuals who have a history of, for example, a suicide attempt, or who have a history of trauma or a mental health problem. But we also need to look at more universal approaches, population health approaches, where we're strengthening our community. And also use our community, our chaplains, our peer and mentors in a community. And we need all of these as different interventions to prevent suicide. So the World Health Organization, they've come out and said, it's really important that all populations have a strategy or an approach, prevention science framework, something that is driving a unified approach, holistic approach to preventing suicide, and really focusing in on having good policies in your community that are supportive of mean safety, of alcohol policies, and also policies that talk about crisis management and that would support behavioral health care and help seeking as well. So here's an example of the Defense Suicide Prevention Office approach, theoretical framework to understanding suicide. And we've taken an integrated approach to developing a prevention science framework. So we leverage at a broad level the Institute of Medicine model. We'll be going into more detail later, and also the ecosystems model. And then as we narrow in We also use Joyner's interpersonal theory of suicide. So we're looking for a holistic, comprehensive model that we can use to guide us with our policies and our placement of interventions that all at the same time are looking at those risk and protective factors and how we can best address them. When we talk about the ecosystem model, this is a model that's been around for a very long time. I remember first learning about it in classes in social work, and I believe it came out in the 70s, but a lot of literature, a lot of studies have talked about the importance of leveraging an ecosystems model. So again, we have coverage of the person's whole life experience. An individual obviously does not operate in a vacuum, and an individual interacts with many different systems. Therefore, we must be aware of all the different systems and know the risk and protective factors in all of the different spheres of an individual so that we can place interventions, policies at all of these different levels so that we have the best opportunity to help people. So the ecosystem model, we have the individual, the relationship, community or unit in the military, and also the societal level. And as you can see, that there's a lot of risk factors at each of these levels and protective factors. And so it's important to work together in these different spheres so that we're addressing all the risk factors in these different areas and leveraging the protective factors so that we have, again, a full comprehensive approach to attacking suicide. The Institute of Medicine Prevention model informs us to, especially on the prevention side, informs us to understand population prevention at the universal, selected, and indicated. Universal strategies, focus on the entire population. In the military, many of the services have universal training programs that talk about the risk and warning signs of suicide, protective factors. In other populations beyond the military and in other countries and also in university settings, school systems, they also teach coping skills, tools to help people deal with issues with the understanding that everybody could benefit from more coping or better coping strategies. The selective prevention strategies are focused on individuals who we believe that there's a general small subgroup that might be at a heightened risk for suicide. For example, in the military, we know that individuals who are separating from the military may be at an increased risk for suicide, or individuals who are new to the military may be at an increased risk for suicide. So that would be an area that we would focus on. And also we can look at who we're going to provide training to. There's gatekeeper training that we may give to individuals who are working in the legal area, and also chaplains, because these individuals may come into contact with individuals that may be at risk for suicide. And then indicated prevention strategies are really focused on individuals who are showing specific signs of suicide. For example, individuals have thoughts of suicide, perhaps symptoms of depression, and maybe a history of trauma. So those are specific symptoms that we're trying to target. So that's an indicated strategy. And the idea here is that we're working all together and we're syncing up universal, selected, and indicated interventions. And they inform each other and they work in unison so that, again, that we can have a blanket approach to preventing suicide. And I'm sure many people are familiar with Dr. Thomas Joyner's interpersonal theory of suicide. This allows us in a adapting some of his concepts into our overall prevention science framework allows us to focus in, dial in into some of the constructs or explanatory mechanisms of suicide. Joiner's theory, interpersonal theory, posits, and this has been very well studied in the civilian population, in the military population, and in the reserve department, and has a lot of empirical evidence that this is a very good explanatory theory of suicide. So the theory goes, and how it's operationalized is, if an individual is experiencing thwarted belongingness, this idea that they're alone, there's nobody there to support them, they have no connection to other people or other organizations, along with feeling a sense of burden that others may be better off without them, they have no more contributions to make, along with an acquired capability, which is in some ways is you're talking about people who've been exposed to violence, to trauma, who are exposed to combat, who've already had attempted suicide, so they have an acquired capability for suicide. And you have all three of these coming together. This has been shown in the literature to greatly increase risk for suicide. Something else that we want to discuss is that we don't want to take our eye off of the entire population. Rose's theorem, which has been around for a long time, and I know the Air Force suicide prevention program uses this idea, that it's important to target high-risk individuals, but we don't want to neglect the entire population, because if we do that, then the rest of the population that we're not targeting, their health, collective health, may decrease. But we need a balanced approach. We need to balance medical and public health. We need good mental health care, access to care, but at the same time we need public health approaches, caring contacts, community engagement. We need to fight stigma, promote help seeking, good policies on means restriction, and alcohol policies. Little differences between the community and medical model. Community model is really focused on trying to keep people in the community as long as we can, and trying to leverage community resources, non-medical interventions, peer support, so that we're trying to prevent the entrance into a hospital. And as it relates to suicide, individuals who are at low risk for suicide, obviously if somebody's at imminent risk for suicide, absolutely needs to go to an inpatient care. But individuals who have ideation, it's been shown in the literature that those people can be maintained in the community, which the literature shows may in turn decrease stigma. Community really matters. Communities play a critical role in suicide prevention. This has been talked about quite a bit by the CDC. You need to foster a community of help-seeking and care and support for one another, and that can be a very powerful tool in preventing suicide. So here's a case example. Communities that care. This has been an evidence-based approach to implementing a community-based public health model, where you identify what the risks are, you identify the stakeholders that need to implement evidence-based practices, you train your entire community, and you provide technical assistance, and then on a continuous process you evaluate the efficacy of the interventions or policies. All right, so this just talks an example again of how important it is to have many different interventions all working together. One interesting point that we kind of need to shift from is that there's over 5,000 articles or more on suicide prevention, and almost 80% of them are on risk factors and on prediction of suicide. Very few articles, relatively few articles, are actually on implementation of evidence-informed or evidence-based practices. So when we go forward in trying to implement a public health holistic approach, we need to continue to focus more on implementing evidence-based or evidence-informed practices. This is an example of some of the available evidence-informed or based practices along the IOM and the ecosystems model. You look at universal, mean safety policies, teaching life skills to individuals at the universal level, and the selective teaching, for example, the Columbia scale to attorneys who may come into contact with individuals who have legal issues. And then the indicated population, there's a good cognitive behavioral therapy model that's been shown to reduce suicide attempts in the military. So going forward, these are just some examples of some of the activities that the Defense Suicide Prevention Office is involved in. We're trying to focus on projects and studies that span the Institute of Medicine model and also the ecosystems model. So in summary, the public health community-based approach to suicide is a community problem that places the solutions with all members of the community. Early active coping strategies and problem solving of stressors is encouraged. You get it left as possible. Focus less on attempting to just identify those individuals who are mentally ill and getting them to treatment, where mental health is very important, but we also need the holistic public health, everybody has a role, prevention approach as well. Thank you. And now I'm going to pass the baton over to Dr. Thompson.
Great. Thank you so much, Adam. What a great summary of a lot of really complicated structures, but so important as we think about suicide prevention as a whole, and especially between the DoD and the VA. It really is such a pleasure to be here today. I am so grateful for the Defense Suicide Prevention Office, for its existence, for the leadership of Dr. Franklin, and because we can't do this alone. We need to do this together. And as I'm saying that, I'm not just saying VA and DoD. I'm saying that all of you also need to be completely engaged and engaged with us and engaged with each other to make sure that we are not missing anyone as we are working through a lot of our public health approaches. Today I'm going to talk about the VA suicide prevention approach as an example of many ways that we have worked with both universal and indicated and selective interventions that Dr. Walsh discussed. But I also want to make sure that I'm providing you all resources out there with things that you can use, you can take back to your communities, both in the military, with veterans populations, and with the general population. We know that suicide prevention is a huge problem, particularly with our veterans and with our military, but it's a huge problem overall in this country, and it's one that we all need to be just continuing to talk about. I want to start out with a few slides to talk about what our public health approach is right now in terms of our messaging. And this is messaging that the VA Suicide Prevention Office and the Defense Suicide Prevention Office have really embraced, as well as branches of service, to really make people know that one small act can make a difference. So this is our Power of One campaign, and so just one small act can make a difference in a veteran's life, in a service member's life, in anyone's life. So for instance, one question can open the door to support. One conversation can show that you care. One call can save a life. I want to let you know that any of the materials that you're seeing throughout my presentation that are specific both to veterans and to the military are available on our veteranscrisisline.net website, and they're publicly made available, and we can help you to coordinate anything that you need in the audience in terms of how to best message to whichever populations you're working with. Briefly, I'm going to talk a bit about veterans, though. I want to make sure that we have just a good context of what our veteran population looks like at this point. So we have almost 22 million veterans, and of course that number continues to shift when people are separating from service and moving into becoming veterans, and also when our older veterans die. And so, for instance, our World War II veterans at this point are about 6% of the veteran population. But I really want to make sure that everyone is looking at that bottom right pie graph on the service era, because so much of what we hear about in the media is about our youngest veterans, those who are post 9/11, as well as our service members. And I just want to remind everyone that half of our veteran population is our Vietnam veterans and are Vietnam veterans and those who are older. This is particularly important as we're talking about numbers, and we also need to make sure, and you all in the audience need to help us make sure, that we are working not just with our youngest veterans who absolutely need and deserve that help, but also we can't forget our older veterans. Just overall, 70% of all veterans who die by suicide are 50 years old and older. And as you can see, our Vietnam era is 35% of our entire veteran population, and that era is continuing to get older as well. And in the general population, we know that those who are 50 years old and older, particularly men, are at especially high rates of suicide. So this is a population that should never be forgotten for anything, but it's also one that we need to continue to remember as we're working on our suicide prevention efforts. What we do know, though, as many of you know, is that veterans are more likely to die by suicide than the general population. So at this point, our latest data for the entire country is that about 44,000 people die per year by suicide, and we know that about 20% of those who die are veterans. What we have found, though, is that veterans who use VA care have lower rates of suicide than veterans who don't use VA care. This is becoming clearer and clearer as we're getting better data across the board. And it's not just VA care, we think it's care in general, but we do know that there's a dramatic difference between veterans who receive care and veterans who don't. Many of you have probably heard the statistic that 22 veterans per day die by suicide. Out of those 22 veterans per day, and it's a complicated number, so it's one to always kind of, it's the best number that we have at this point, but there are complicated ways that we got to that. But out of those 22, 17 of those veterans have not sought VA care. So it's a huge number of veterans who have died by suicide, who have never touched the VA system. And again, I think that speaks to some of the strategies that VA is doing and some of the things that we continue to learn from all of you and how we can work together in order to make sure that we are finding those 17 veterans who aren't tapping into VA care and figuring out how to best serve them. Overall, though, even though I just said that veterans who are 50 years old and older have higher numbers of suicide, the rates of our youngest veterans, male veterans in particular, between 18 and 29 years old, continues to go up. And this is just very, very concerning. And so a lot of our outreach that, again, we are developing with the DoD and the Defense Suicide Prevention Office is really making sure that we're targeting those youngest veterans and particularly thinking through the best ways for them to transition from being in service to either the VA system or being a veteran and getting that level of care that they need. We're also really concerned about our female veterans. We know that even though this is a bit of a deceiving graph, the numbers of women veterans who are dying by suicide continues to go up. And what we have also found is that those women veterans who are not in VA care have much higher rates of suicide than women veterans who are in VA care. A number of reasons related to that that we can talk about in a bit. So just overall, again, this is the VA's approach to suicide prevention, but it's also one that has been really taken on by the Zero Suicide Initiative across the country, which is really the idea behind it is making sure that there is a culture of understanding suicide prevention efforts among everybody within that system, and that happens through training, through our enhanced care delivery system that, again, the Zero Suicide efforts and other systems have really championed. It's in terms of research, our access to care, and our awareness and outreach. I just want to briefly talk about our enhanced care delivery system because I think it is a very important component, and it speaks to that more of the indicated intervention that Dr. Walsh discussed earlier, where when we know that a veteran is at high risk for suicide, we have specific things that we do in order to make sure that that veteran is kept as safe as possible. First of all, we have what's called a high-risk flag. It's a flagging system within our nationwide electronic records. And so that if I, as a veteran, go and see my podiatrist and I was at high risk for suicide, my podiatrist would say, would open my record, notice that I was at high risk for suicide, and have the opportunity to have a conversation with me about how I'm doing mental health-wise or otherwise, just in general, as opposed to just talking about removing calluses from my feet. And that is huge. That's speaking to that culture that we've really been striving to and continue to strive to enhance throughout the VA system and then through a lot of our community providers. We also have a safety planning requisite so that any high-risk veteran who is at high risk for suicide is provided with and in a collaborative way develops a safety plan in order to ensure that steps are in place if the veteran is feeling like they're not doing well. And so it includes coping strategies that they themselves can use. It includes phone numbers of people who can distract them, who they can talk with, who are personal friends or family members, as well as professional organizations, and it especially speaks to the discussion about means and the ways that people can keep themselves safe. For example, using a gun lock if they have firearms at home, making sure that medication isn't stockpiled, and so talking through, okay, who can you give, the extra medicine that's in your medicine cabinet, who can you give that medicine to, especially at for the time being that you're going through this crisis. So a very important component of our work, and if you're interested more in our safety plans, we are happy to provide any further information on that. We have the Veterans Crisis Line, which we are extremely proud of, and the Veterans Crisis Line has been double branded as the Military Crisis Line. The phone number is 1-800-273-8255. Press 1 for those who are veterans, service members, family members, and friends of veterans and service members. I worked at the Crisis Line for 5 years, and I can tell you there is nowhere such an incredible group of people who are working on those calls every day, 24 hours a day, working on our online chat system as well as our texting service. These are extraordinary people. There are a lot of them because, as you can see, a lot of people have been using this service. We've received about 2 million calls since it was established in 2007, and I think especially important is that the Crisis Line has become a conduit from this national call center to local care. We're working right now with the DoD to help and to really understand how they do that when someone might be in crisis, knowing then that you need to get somebody into longer-term care, because we know that treatment works. We know that people can get better, and we know that when people are feeling suicidal and they get better, it's most of the time that they don't feel suicidal again. So we need to get everybody into treatment. With that in mind, we have a very elegant system where we are able to refer callers to their local VA suicide prevention coordinators around the country. We have over 300 suicide prevention coordinators nationwide at every VA medical center and every community and large community-based outpatient clinics in the center. I'd like to say hi to a lot of them because I know they're on the call right now. But again, talk about extraordinary work. These are also your champions for veterans that you may be concerned about who are suicidal in your local area. I'm going to show you how you can find out who those folks are, and I also just want to talk a little bit about what they do. As I said before, there is this referral service from the crisis line to suicide prevention coordinators. When a referral is made, and the veteran has to agree to this referral, and many of them do, as I said, or I don't even know if I said, but we've had more than 320,000 people referred to the suicide prevention coordinators since the program was established in 2007. Once that referral is made, the suicide prevention coordinator is required to call the veteran back who called the crisis line within 1 business day, so within 24 hours. That's for anybody who is not at imminent risk for suicide. With those folks, those are the number on the far right where we talk about the 53,000 dispatches of emergency services that have had to have been made because veterans and people who have called the crisis line have perhaps been in the process of killing themselves. They may have already taken the pills. They may have not been able to have put away the gun. And so therefore we need to get people out there immediately, just like any crisis center around the country, not just ours, needs to get people out there immediately to lay eyes on that person who is so unsafe at that moment. For those who are not at that level of risk, we have, as I said, this system where these referrals are brought to the suicide prevention coordinators. Within 1 business day, the suicide prevention coordinator contacts the veteran back and ensures that that long-term care is going to be set up. Perhaps they enroll the veteran in services. Perhaps they find other services outside of VA if the veteran isn't eligible for VA services. Again, they are the local champions for veteran service suicide prevention. Our suicide prevention coordinators are also required to do at least 5 outreach events per month in their local community. So this ensures that we are not just tapping into those veterans who use VA, but trying to find veterans outside of our system to make sure that they are aware that these services are available to them too. Anyone can call the crisis line if you're a veteran, no matter what your discharge status was, no matter how long you have not been in VA care or if you've ever been in VA care. Family members and friends can call on behalf of a veteran, and this is again for those people who are in some level of crisis. So these outreach events can range from going to a baseball game and setting up a table, providing information on suicide prevention efforts, again, to continue that conversation that just needs to be had if we're going to keep our veterans our service members safe. So we do a lot of outreach and speaking engagements. These are some of the examples of the types of outreach that we do. I also want to talk briefly about our Operation SAVE training. The DoD, lots of the branches have their own gatekeeper trainings. Gatekeeper training is a training that is suicide prevention or crisis intervention related where you find out the basics. How do I know if somebody is feeling suicidal? So the VA-specific training is called Operation SAVE, and I'm going to run through what that is. So it's teaching, it's about a 1 to 2 hour in-person training, and it's teaching, first of all, what are the signs of suicidal thinking or crisis that should be recognized. If I'm sitting across from a veteran, or if I'm sitting with my spouse who is a veteran, what are the things I need to be really watching out for and making sure that I'm aware of if I'm at all concerned about the veteran, which includes things like discussions of hopelessness, increased alcohol use, things that I can then recognize and then I can do the next step, which is asking the most important question of all. And what is that question? That question is, it's turning to someone and saying, I am so concerned about you right now. Have you been thinking about suicide? Have you been thinking about taking your life? Have you been thinking about killing yourself? And boy, is that a hard question to ask. We know that a lot of people are concerned about asking the question because they fear that if they ask the question, it will put it into someone's head, and they will know then that that person will then follow through, and then it will be the person's fault who asked that question. And I am here to tell you flat out, research has shown this is not the case at all. Asking that question to anybody opens up the conversation so that person who has probably some of the most difficult thoughts and feelings that they've ever had before feels that you are not scared to talk with them about this, and that you are opening up that conversation and saying to them, which is validating the veteran's experience, which is the V for SAVE, which is saying to them, this sounds like it must be so painful. I am here to help you get help. Let's walk through this together. We're going to help you feel better. This must be so hard. And then teaching through this model, teaching people how to encourage that treatment or expedite getting the help that is needed, either at that exact moment of time, whether somebody needs to go to an emergency department right away, or whether they need to continue to follow up with their physicians or their counselors or get more engaged in care. Operation SAVE is provided to all VA employees who work in the hospitals and the outpatient clinics, to all of them, and this is not just clinicians. This is provided to those who work in the canteen, those who are electricians, and again, this is promoting that idea of that culture that everybody needs to be aware of this problem, and we all need to be working together on it. And Operation SAVE can also be provided by our suicide prevention coordinators to organizations like yours as part of their outreach strategies. And so if you're a VSO that's out there and you're looking for some education for your chapter, that's one thing that our suicide prevention coordinator can do. And I'm going to show you I'm going to tell you how to find them. I'm just going to place this up here for a moment. These are some of the warning signs that we talk about. Hopelessness is really a very critical one. If somebody is feeling like there's no way out, we know that that is a huge risk factor or a huge warning sign for those who might be feeling suicidal. Also, thinking about when people are going through transitions in life. That may be a transition based on a breakup of a relationship. It may be a transition like moving from being a service member to becoming a veteran, losing a job. These are moments when people are at their most vulnerable. Overall, not just veterans and service members, are at their most vulnerable and may be considering suicide in ways that they haven't before. So those are also times to watch out for ourselves, all of us. The VA Suicide Prevention Program has also, as I know the Defense Suicide Prevention Office is doing too, we talk so much about safety. And we have a gun safety video that I encourage all of you to watch, share, and it is all about the idea that that keeping yourself safe during a moment of crisis is absolutely essential. And we also provide free gun locks to all of our veterans, family members across the country, and your suicide prevention coordinator at your local VA can help to provide those. We have a lot of PSAs on our website that you can also share. Again, this is another part of that public health model that Dr. Walsh talked about earlier, where we are trying to step back and make sure that everyone is aware of this issue and get that messaging out there. We have campaign materials, and then we have what's called a partner outreach hub. So this is for any of you, including those who are out of the DoD or branches of service, where you can find so many of our materials. Again, just go to veteranscrisisline.net, NET, go to the Partner Outreach Hub, and you'll find a lot of these videos, these PSAs. You'll be able to share things immediately directly to social media, to your organization's Facebook page or your websites. And this is our resource locator, and this is particularly important if you're looking for things like who your suicide prevention coordinator is in your area. You can put in to find out where your local vet centers are. Vet centers are also a hugely important piece of our suicide prevention efforts because it's one place where a lot of veterans really get their help. As I'm wrapping up, I want to briefly just point out Make the Connection, maketheconnection.net, another big public health resource where it is for all veterans and service members and family members. It has videos, hundreds of videos of testimonials from veterans and service members and their family members talking about how they got help. We rarely hear about this. We hear about the really horrible stories, which we do need to hear about, but we also need to hear about the stories of success where people have gone through a horrible situation or are struggling with something and they've gotten better. And you're able to decide, you're able to really pinpoint who you are so that the people on the videos can really speak to you in terms of being, for instance, a male Vietnam veteran or era veteran. If you click on that, then all of the videos that will come up will be people who look like the people that you may be working with. We have a lot of other resources. I know you all have the information, but I especially want to provide my information. I am as available. I'm pretty available. I'm pretty busy, but I am always interested in hearing people's thoughts and in collaborations. And I can also send you to all the right people as far as suicide prevention efforts for veterans. Again, pleasure to be here today, and I'm going to turn it back over to Dr. Bates.
Okay, thank you, Dr. Thompson. It's now time to answer questions from the audience. If you have not already done so, please submit questions via the Q&A pod located on the screen. We will respond to as many questions as time permits. The first question will be for Dr. Walsh and Dr. Thompson. Given the range of resources available, are there reasons for identifying specific resources to consider first?
Given all of the resources available, thinking about those that are, yes. Well, I think so. I mean, it's always important to make sure that the resources that are that you share or that you use yourself are, first of all, have been vetted in some way. So as far as any veteran or military or DoD resources, know that those have been vetted very, very well. And so I would say to start from there, but there are other extraordinary organizations, community partnerships that we have that include things, places like Give an Hour, like the American Association of Suicidology, the American Foundation for Suicide Prevention, and they provide extraordinary resources that can really speak to anything that you're looking for. And I also want to just point out the Suicide Prevention Resource Center, which is SPRC, which is just this kind of library of the best resources that might be available. Dr. Walsh, anything else?
I think the only thing I would add is if people are looking for treatment options, the SAMHSA website has a registry of evidence-based practices and treatment interventions. So if you have somebody who's looking for treatment for depression or disorders related to suicide, that you may want to take a look at what is the evidence, what are the most effective treatments.
Thank you. The next question is for Dr. Walsh. Could you speak a bit more to the concept that individuals with SI can better be maintained in the community?
Yes, I know that there's been quite a bit of research done. Dr. Rudd, Dr. Joyner have written books on suicide assessment, clinical assessment of suicide, and also the development of the Columbia Scale with Dr. Posner. There's been quite a bit of work that's looked at levels of risk for suicide. And if individuals who have ideation, who may not have a specific plan or who is deemed imminent risk for suicide, those individuals can be and have been maintained very well in the community through outpatient treatment and through community resources.
Okay, thank you. The next question is for Dr. Thompson. How can we incorporate the spiritual component of the human experience into EBP for people at risk of suicide? I read an article on veterans getting good results with Native American sweat lodge ceremonies for PTSD and combat experience.
What a great and important question. I'm going to close this because it's too distracting for me. So such an important component of people's recovery can be their religious and spiritual beliefs and their faith. And so I know that there are certainly studies that are going on that are looking to ensure that that they become evidence-based practices. Of course, there needs to be a collection of papers in order to establish something as being evidence-based, but certainly this is not just something that we need to think about as far as being an evidence-based practice, but something that we need to consider as we're talking with our veteran service members and everyone about what works for them. What are the protective factors in terms of somebody who might be feeling suicidal? So many times it may be going to a sweat lodge for that evening, and it's just their own personal individual experience. But I do know work that is being done, and I hope that there is more that will continue to be done.
Thank you, Dr. Thompson. And for Dr. Walsh, how helpful is technology and the public health approach to suicide prevention?
Well, technology can absolutely be leveraged. I know through, I believe the Veterans Crisis Line, you have online capabilities, and I know that the services as well, they're working on telehealth options, and there's some good evidence that shows that evidence-based treatments can be delivered through webinars or through telehealth, and so that can be very useful.
Thank you. And the next question is for Dr. Thompson. What % of crisis line counselors are veterans?
Great question. I don't know the exact percent. The last time I was aware, I believe it was up to about 30% are veterans themselves, but I'm not sure exactly at this moment, but it's certainly a strong component of the crisis line responders. But I also want to say that many of our crisis line responders are also family members, spouses, children and parents of our veterans and service members.
Thank you, Dr. Thompson. And for Dr. Walsh, what are the biggest gaps in implementing a public health approach, or where are the greatest opportunity for enhancing a public health, community-based, and holistic suicide prevention approach?
I think it's something that we all are dealing with, and that I think one of the best opportunities or gaps is to continue to work with, lashing up the medical approach with that public health approach. Mental health treatments are incredibly important, and having a comprehensive, synchronized effort between non-medical public health interventions that may not be providing medical treatment and treatment providers, treatment facilities, having that care coordination, having that communication working in unison, I think, is our best opportunity.
Thank you, Dr. Walsh. And for Dr. Thompson, I'll be going to a Train the Trainers course for the peer-to-peer assist via Team Rubicon. I also work for the VA. I'm wondering how we could integrate the peer-to-peer aspect that assist offers into the VA.
Boy, what a great point, and I am such a Team Rubicon fan. That is fantastic that you're doing that. We also know that the assist model is a fantastic model. It's one that many of our suicide prevention coordinators have gone through. Most of our crisis line responders have gone through that model too. Regarding peer-to-peer, we are at every VA, at most VAs around the country, we have peer support specialists. Those numbers are going up, and these are veterans who have also had lived experience with mental health concerns and mental health issues, who are now federal employees who really work as peers for the veterans who work with them. So I think that this is absolutely something that can be expanded upon, and I'll help to think through that more. Thank you.
Thank you. And for Dr. Walsh, how do we measure and track the most important risk and protective factors?
I think there's a lot of literature, a lot of results out there that talk about the most common, most prevalent risk and protective factors across populations. There's some really good research out there from Dr. Kessler and from other researchers who have taken a public health approach to identifying risk and protective factors. But it may vary some depending on your population that you're working within.
Thank you, Dr. Walsh. And Dr. Thompson, how many gun locks, as an estimate, are issued monthly?
Boy, that's a good question. I believe we have, I can't say monthly because I think it really depends on how many are asked for, but we have provided, I believe, over about 2 million gun locks across the country. I want to really make sure that the audience is aware that these are provided anonymously. There are no questions asked. You can go up to your suicide prevention coordinator and just ask for a gun lock, and they'll just give you one. There are some VAs across the country that have buckets of gun locks as you walk into their VA, and it's just a perfect, talk about a great public health approach. It's such an important way to really make sure that our veterans are kept as safe as possible, and we will continue that program as long as possible.
Thank you. And Dr. Walsh, what is the virtual Hope Box?
The Virtual Hope Box has been developed by Dr. Bush, Nigel Bush from telehealth and telecommunication, and it's a suite of a variety of different tools that can be accessed by your phone. It's an app, online app, and it can be used. The evidence, or how it's been researched, is to be used to augment counseling or treatment. But I know that a lot of other people use it on their own or with peer-to-peer models, and it shows you reasons for living. As a therapist, I remember the old days of taking a shoebox and working with a client and putting their reasons for living inside a cardboard shoebox and giving them hope, things that they can remind themselves of when they're feeling hopeless. And this is the virtual application of the cardboard shoebox. So you, if you're working with a client or if you're by yourself, you would put in photos, you'd put in things that maybe spiritual scriptures, whatever it might be, that gives you hope into the application. Also gives you some evidence-based coping mechanisms and helps you develop a coping card. So it's a very, very useful tool.
And it's available?
It is available.
The app stores?
I will have to, yes.
Great. So it's available to anybody out there. Yeah. Great. Just Google it.
All right, thank you. And for Dr. Thompson, have you all considered partnering with the VA Office of Patient-Centered Care and Cultural Transformation's Whole Health Coaching Initiative? There are powerful tools being used to help us shift the conversation from what areas of your 8 dimensions of wellness would you like to work on to give you powerful reasons to live. Here is their cloud, and they provided a internet address we can provide later.
Fantastic. Let's talk. Yeah, absolutely. I would love that. And at this point, certainly internally to VA, we are really continuing to strengthen our collaborations as well as externally. So I'll look forward to touching base with whoever that is. Thank you.
Okay, and for both doctors, what role does or can social media veterans groups play, as several identify their reason for being is to reduce the 22 per day?
Sure, I can. Yeah, this is so much. The social media can be used to such a great extent. I have to give a shout out to my friends at AMVETS who are especially focused on this issue, particularly out in the state of California and the state of New York, who have used social media to such a great degree and ensured that we are collaborating with them in order to provide the best information possible. And we are looking to collaborate with any other group related to any social media. As I said before, we also have our Partner Outreach Hub on our Veterans Crisis Line website, where you can just download anything to post that might be relevant to your group related to suicide prevention efforts. But this may be one extremely important way to find those veterans who are not tapped into care and to provide them with the information about the important resources that are available to them.
Thank you. And Dr. Walsh, how do you provide services for children of service members or veterans?
I'm going to defer that to Dr. Thompson. How do you provide services to children of veterans?
Sure. Well, I mean, related to service members, of course, there are huge military family initiatives that are available, and I know the Defense Suicide Prevention Office has those connections with military family groups, and so continuing to really work with them, I think, is extremely important. As far as VA goes, we have materials online through the VISN 19 MyRec website, and I can provide that link at some point. But it's talking about how to talk with your children about perhaps if a parent had a suicide attempt. And we're also continuing to collaborate with other groups who serve children and family members in ways that we haven't been in before. So if you, whoever asked that question, have any thoughts of who some more of those groups might be, please let me know.
Okay, thank you. And here's another VA question. When looking at the data regarding veterans who died by suicide and did not use VA services, are you considering those who were OTH dishonorably discharged who do not have access to these services?
Yes. And especially as we are learning more and more about those who have had other than honorable discharges, and we know and we have found that their rates of suicide are in fact higher than veterans who have been honorably discharged. So so when we're looking at those rates, yes, these are people they would be in the group that does not use VA services. I do have to remind to let you know, though, that if you are working with veterans with other than honorable discharges and you need to help them find community resources, certainly our suicide prevention coordinators can help with those. And again, vet centers are very much can work with many of those veterans who need that care. We are also currently working and looking at legislation because it has to be congressionally mandated in order for VA to see veterans who have other than honorable discharges, and we are great proponents of that.
Thank you. And the last question goes to Dr. Walsh. What are the SI rates for dependents of the military personnel? Are there any actions the DoD is taking to address the needs of the dependents?
In fact, there's new legislation that's out that we will be starting very soon, tracking the rates of suicides, deaths by suicide of dependent service members. So that's a process that we've been working on and something that we'll be implementing very soon. In terms of the rate of ideation for dependents, I do not exactly know the rate. My best educated guess is it's probably fairly similar to the civilian population, but we will gather more information as this new legislative mandate goes through about dependent family members and suicide-related behaviors.
Thank you, and I'd just like to say thanks for all of us for this very informative presentation on a critical issue.